Okay, my topic is about the etiology, diagnosis of myocardial hypertrophy based on CMR. As I'm a cardiologist, I'm not a radiologist, so I will introduce 4 cases of patients with myocardial hypertrophy and talk about the CMR characters. These are the various diseases related to the left ventricular hypertrophy. The most common is the hypertension and also the aortic valve stenosis, and also just like the Matthew talked about the exercise-related left ventricular hypertrophy. And also we will talk about the hypertrophic cardiomyopathy and the cardiac amyloidosis and Fabry disease and Danon disease and mitochondrial cardiomyopathy. And next, I will introduce 4 cases about the hypertrophic cardiomyopathy and the cardiac amyloidosis and Fabry disease and mitochondrial cardiomyopathy. The case 1 is a 49 years old male patient. The chief complaint is chest tightness for 7 years, and he has no obvious family history of heart disease. The physical examination, we found that he had a systolic murmur at the aortic valve area radiating to the neck. And in the laboratory test, we found that he had an elevated troponin, and he had the heart failure symptoms with elevated BNP. Let's see his ECG. We can see the high voltage QS level in the precordial leads, and also the deep S wave in the precordial leads. We also can see here the T wave inversion in leads V2 to V4. We performed the echo for this patient. We can see here the septal was very thick. Okay, the septal thickness is about 25 millimeter, and the left ventricular post wall is about 12 millimeter. The patient has a normal systolic function. The left ventricular ejection fraction is 42. Is 62. And we check the left ventricular outflow tract pressure. We found that the pressure gradient is more than 80 millimeter. So the patient had a left ventricular outflow tract obstruction. We did a coronary angiography for this patient. The coronary artery is mainly the right dominant tape, and we can see here there are no significant stenosis observed in these patients. So the patients had no coronary artery disease. This is the CMR for this patient. We can see here he has asymmetric hypertrophy. The septal wall is very thick, and the left ventricular post wall is also thick, but it's not so obviously like the septal wall. And in this thing, we can see here the left ventricular outflow tract is obstruction. The flow tract is narrow. Okay. This is also the CMR imaging. Okay, we can see the systolic anterior motion sign here. The systolic anterior motion sign is that the anterior displacement of the mitral valve move toward the septum during the systole. This is the CMR LG enhancement. We can see here, just like Matthew said, we can see this is a typical case. I choose the typical case. We can see the enhancement at the right ventricular insertion point to the left ventricular. The there are two insertion points, and also we can see the patch mural enhancement with the septal wall. Okay, here, septal wall. Also, we should to differentiate diagnosis from these patients with other diseases can lead to the left ventricular hypertrophy. The most common is hypertension. We know in patients with long-term hypertension with uncontrolled blood pressure, it also can cause left ventricular hypertrophy. Also, however, the patients with hypertension, the hypertrophy is also mostly symmetrical. Okay, symmetrical. The septal wall and the left ventricular post wall is also thick, and there are no significant difference. And we cannot see the outflow tract obstruction for patients with hypertension. And normally in patients with hypertension, we do not see much LG enhancement. Okay. Also, another differential diagnosis for left ventricular hypertrophy is the aortic valve stenosis. Also, in patients with aortic stenosis, the left ventricular hypertrophy is also symmetrical. The same in the septal and the same in the lateral wall. And also, if we to check the valve of the patients, we can see the transvalvular pressure gradient very high. Okay. Also, in these patients, these are pressure-related left ventricular hypertrophy. We commonly see no significantly LG enhancement. However, for patients with hypertrophic cardiomyopathy, there are a lot of different types, different forms. The hypertrophy of the heart can happen at any part of the heart. The hypertrophy can happen at the basal, at the middle part, and happen at the apical. Okay, the different type of hypertrophic cardiomyopathy. And also, in some patients, even the septal wall is thick. The outflow tract is not obstructive, but in some patients, the basal septum is very thick. It will cause the obstructive hypertrophic cardiomyopathy. This is typical, I find from the article. Okay. This is a typical symmetrical hypertrophic cardiomyopathy. The most significant thickness of the wall is in the septum. Okay. And the typical LG enhancement is in the super and inferior insertion point of the left wall to of the right ventricular to the left ventricular. Okay. And this is the apical hypertrophic cardiomyopathy. Okay, we can see the ace of spades. This is a very typical sign of the apical hypertrophic cardiomyopathy. And in these patients, we also can see here the very giant negative T wave inversion, okay, and also the increased QRS voltage. There are other forms of hypertrophic cardiomyopathy. In these patients, okay, I also find from the article, okay, not patients from our center. Okay. These patients had a hypertrophy of the heart at the middle part of the heart, and it will cause an apical aneurysm. Okay, apical aneurysm. Okay. Also, we can see that there are mass-like hypertrophic cardiomyopathy, and in this patient, we can see the right ventricular is also very thick. This is RV involvement. And also in the late stage hypertrophic cardiomyopathy, we can see the reduced the ejection fraction and diffuse LG enhancement. And this is the hypertrophic cardiomyopathy. And case 2, it was a 6-7-year-old male patient. The chief complaint is this chest distress for 5 months. We perform an echo for this patient. Okay, we can see here have a very thick septal. Okay, about 17 milligram, and the left ventricular post wall is 13. Okay, and he had no medical history of heart disease, and the coronary artery angiography in other hospital is negative. We don't find significant coronary artery disease. The ECG is very interesting that we can see the low voltage QS. The patients with the left ventricular hypertrophy, but with the low voltage, it is not matched to the hypertrophy. And we can see here in the precordial leads, the Q wave from V1 to V5, pseudo infection, like patients with myocardial infarction. We did the serum test for the light chain for these patients. We found the positive results. You can see here the M-type M protein IgG it was positive, and this supports the AL-type cardiac amyloidosis. The urine test also is positive. Okay, it also supports the diagnosis. We also perform the PYP2 test for these patients, but we found no significant myocardial uptake. So this patient is this test does not support the ATTR type amyloidosis. This is the CMR for this patient. We can see he has a thick left ventricular wall, and both in the septal, also in the lateral wall. Okay, the hypertrophy is symmetric. And for the LG enhancement, we can see here is diffuse. All the 4 chambers of the heart were involved. Okay, so this is cardio amyloidosis. Okay, this is not the imaging for our patients. This I find from the article. Okay, so also very same with our patients. Okay, the diffuse enhancement of the whole heart. And for patients with amyloidosis, the T mapping was elevated. This was totally different with Fabry disease. And next we will talk about the patients with Fabry disease. Also in patients with amyloidosis, we can see the dilated left atrium, and the whole heart will be involved in the LG enhancement. Case 3, I will introduce the female patient with 58 years old. The chief complaint is back pain after activity for 8 months. The UCG also showed that he have a very thick left ventricular. The septal is about 16 millimeter, and the post wall is about 10 millimeter. She had a medical history of hypertension, and the coronary test also showed she had no coronary artery disease. Let's see this ECG. Okay, it's also a very high voltage QRS, and also diffuse T wave inversion from V2 to V6, and lead 1, lead 2, and lead AVL, very like the hypertrophic cardiomyopathy. But we sent the GLA test, enzyme test for these patients, and showed the significant reduced the GLA enzyme activity for these patients, and the lyso-GL3 was significantly elevated. We also do a gene test for the patient. We found that there were two mutations in the GLA, and one was pathogenic, and another is VUS. We diagnosed this patient with Fabry disease. Okay. In patients with Fabry disease, the left ventricular hypertrophy is commonly symmetrical. Okay, and the LGE in these patients often happen to the inferolateral part of the left wall, and most importantly is that the T1 mapping in Fabry disease is generally low. And case 4, this was a 66-year-old male patient. The chief complaint is the chest distress with exertional symptom, and this patient also has a symmetric hypertrophy. We can see his septal and posterior wall of the left ventricle is both 50 millimeter, and he had a medical history of diabetes and hearing loss. We do the laboratory test for this patient. We found an interesting thing that he had a significantly elevated lactic acid. Okay, and this is CMR for this patient. We can see here the left ventricular is symmetric hypertrophy. Okay, and the LG enhancement is observed within the subepicardium and the middle layer of the left ventricular. We did a endomyocardial biopsy for this patient. We found the mitochondrial proliferation with swelling and degeneration. We also do the genetic testing for this patient. It was a typical M3243 mutation. So this patient is a mitochondrial cardiomyopathy. The typical CMR finding for mitochondrial cardiomyopathy is that there are diffuse left ventricular wall thickness, okay, both in the septal, also in the lateral wall. And for the LGE enhancement, we commonly see the enhancement in the subepicardium and the middle layer of the left ventricular. This is another article. Okay, I found there are diffused left ventricular hypertrophy and in patients with mitochondrial cardiomyopathy, and this patient has extensive patch LG enhancement in nearly all the segments, and but it is prominent in the middle inferior septum. And we also see in the T2 imaging, okay, the T2 hyperintensity was matched to the LG enhancement in the region. Okay, so that's my presentation. Thank you.